Okay, to complicate things for my computer, I actually stopped that recording and submitted it by accident instead of pausing. So it's going to be in Moodle on week 8 as exam 3 review number 1. And so you can listen to that one, and then this one is going to be labeled exam 3 review number 2. Sorry guys, anyways. Okay, so we are doing chapter 28, and that is birth-related stressors for the newborn. A lot of this is going to be redundant, but that's okay because redundancy helps learning. So we're going to start out with your asphyxiated newborn. So you've got a baby who's had some intrauterine asphyxiation and is born and now is having an asphyxiation problem. Okay, so in utero during labor, an asphyxiated baby is going to show you that with their heart rate. Okay, so they're not going to have a good heart rate pattern. They're going to have absent or minimal variability. They're going to have may have marked variability. Now remember, absent variability tells us that variability tells us our oxygenation status of our baby. So if we have absent variability, we have absent oxygenation. Okay, that's bad. If we have minimal variability, we have minimal oxygenation. That's bad. If our baby is not sleeping, or if we did not just give a narcotic to our mom. Okay, if we have a minimal variability throughout our entire labor, then that's bad. Okay, if we have marked variability, then that's our baby who's telling us, I am having an oxygen problem, I'm doing everything in my power to make it better, and I'm going to get tired and I'm going to crump. Okay, so baby shows that on our fetal heart rate tracing. Baby will also maybe have some decelerations on the heart rate tracing that tell us that they're having a problem with oxygen. Now remember, early decelerations is head compression. That means the head is coming down into the birth canal, and that's fine. That's not a bad sign. Okay, but a variable deceleration and a late deceleration are bad. Prolonged decelerations are bad. Okay, that tells us our baby is having a problem. Bradycardia is bad. Tachypnea is, our tachycardia is bad on the fetal heart rate tracing. Okay, anyways, we can anticipate problems with our baby depending on our mom's history. Okay, so make sure you know your mom's history. All right. Okay, so we may need to be resuscitating our baby at birth, so we put our baby on the warmer, position our baby on our back with our head slightly extended to open our airway. We dry and stimulate our baby. If our baby does not start breathing or is only gasping, we will start positive pressure ventilation. Okay, we do that for 30 seconds. Okay, we do that for 30 seconds, and then we listen to our heart rate. And if our heart rate is below 60, we continue doing positive pressure ventilation, but we add chest compressions. Okay, if our heart rate is between 60 and 100, then we do positive pressure ventilation. Okay, and then hopefully our heart rate will continue to rise above 100. Okay, if after 30 more seconds we've done positive pressure ventilation and or chest compressions, if our baby is not improving, we may be intubating, and we may even be giving epinephrine. Okay, but then our NICU nurses will be taking over promptly. Okay, look on page 669. There are 2 ways to do chest compressions on a newborn, and that is the 2-thumb method, where you grasp the baby's chest on either side with your hands, your fingers on the baby's back, the thumbs on the baby's sternum, and you do compressions that way, or you do the two finger method. Okay, so you can look at that really quickly. And remember, as I said before, 10% of your babies that end up with a resuscitation, usually it is just the positive pressure ventilation, and then you improve babies' course with no further resuscitation. Okay. Okay, so let's talk about respiratory distress syndrome. If you see respiratory distress syndrome, then you're going to think surfactant. That is what you're going to think. There is a surfactant problem. So either your baby was born premature and did not produce surfactant, therefore the surfactant is what helps babies keep their alveoli open on expiration, okay? So they don't have that, so their lungs their alveoli collapse after expiration, okay? That's a surfactant production problem, a deficiency in surfactant, okay? So that's a prematurity problem. The other problem is something happens that denatures surfactant. So that's your aspiration syndromes, okay? So baby is aspirated, and whatever baby is aspirated has denatured their surfactant, okay? So they're going to have respiratory problems. When you see respiratory problems with baby, no matter what their respiratory issue is, this is what you're going to see. You're going to see grunting, or you're going to hear grunting. It's that cute little sound where mom says, oh, my baby's singing. Oh my gosh, that's not cute and that's not singing. That's grunting. Baby is closing the glottis to help create pressure in the lung, okay, so that they can oxygenate. Okay, so you're going to hear grunting. You might see nasal flaring. Babies are nose breathers, so they're flaring their nose up to get large volumes of air in, okay? You're going to see retractions. Now you can see retractions between the ribs, under the sternum, or above the sternum, okay? So intercostal retractions, substernal retractions. So you're going to see all those different kind of retractions. And then these babies are going to be on continuous pulse oximetry, and then you're going to have, you're going to see oxygen saturations below 90, okay? So we need to oxygenate these babies. We possibly need to be giving some type of positive pressure on these babies. These babies may be possibly intubated. Okay, what other problems are you going to see for these babies? Well, if you're hypoxic, what is going on in your blood? Okay, hypoxemia will create acidosis, okay? Now in the lungs, what's going on in the lungs? Baby is not exchanging oxygen and not exchanging CO2, so that's creating increased CO2 in the blood, so that's a respiratory acidosis. So now you have a metabolic blood acidosis and you have a respiratory CO2 acidosis, okay? So these babies are probably going to be intubated. The best way to correct these acidoses, both of them, is ventilation, okay? All right, so there's that about these babies, okay? With these babies, what else are we going to watch? We're going to make sure these babies stay warm, and we're going to make sure these babies' glucoses are good, okay? Now, you have transient tachypnea of the newborn. It means exactly what the title says. It's transient, okay? So that means it's going to go away. It's tachypnea, so that means the baby is going to be breathing fast, and it's a newborn, okay? Usually a term or a late preterm baby, okay? But transient tachypnea of the newborn is these babies are breathing fast because they still have fluid buildup on the lungs. They haven't absorbed, it hasn't evaporated, they haven't breathed it off, and so their oxygen exchange is impaired, and so they're breathing very fast so they can breathe in more oxygen, okay? This is transient. This can resolve in an hour. It could take a couple of days. We don't know how long this will take, but we will support this baby. We will give this baby supplemental oxygen until this baby is better. Now, do you feed this baby who's breathing very fast? Now remember, these babies, when they're feeding, they have to suck, 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 swallow, then breathe, okay? But if you're breathing at a very fast rate, your ability to suck, 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 swallow, and not try to breathe at the same time is diminished. So this baby is at increased risk for aspirating. Okay, so do we really want to feed these babies? Now, depending on your pediatrician or the neonatologist, wherever this baby is, depending on how fast that they're breathing, they will decide whether or not these babies can feed. Okay, so if these babies are feeding less, or I'm sorry, if these babies are breathing less than 80 times a minute, they might be able to bottle or breastfeed. However, maybe not, okay? If they're anywhere between 60 and 70, maybe they can breast or bottle feed, okay? But if they're breathing faster than that, like definitely not, because like they're not going to be able to suck and swallow fast enough to get their next breath, so they're going to aspirate. The other thing with these babies who are breathing really fast is, do you really want to be filling up that belly and having a full belly and impinging on their ability to breathe yet some more? So these babies may be on a D10 IV drip until they're able to slow their breathing down, okay? But these babies may, the doctor may say, yeah, I want this baby to eat, but this baby can't breastfeed or bottle feed, so we're going to stick a tube down and feed the baby through the tube, okay? So you might be doing that. What else do we have here? Meconium aspiration syndrome. Okay, so they did aspirate meconium. This is so devastating to the babies. So if you've ever cleaned meconium off a baby's butt, you know how thick and hard that is to clean off. Can you imagine having that sludge in your lung? Okay, so it just doesn't take a couple of days to work this stuff out. This could take weeks and weeks and weeks. This baby is a patient in the NICU, okay? Severe damage to the lungs. Big problems for these babies, okay? I'm not going to spend a whole lot of time on this. This is such a NICU problem for a long time. Okay, moving on, cold stress. I've talked about cold babies. We don't want babies cold, and if we get babies cold, we're going to start having hypoglycemia problems. We're going to start having respiratory problems, and it's just a vicious circle. The next section is the hypoglycemia babies. We've talked about that to death as well. Hypoglycemia is a baby whose blood sugar is less than 40, okay? Do we need to hook this baby up to an IV if their blood sugar is less than 40? Not right away. Let's try to feed the baby and see if we can get baby's blood sugar stabilized with the minimum intervention possible. So let's try to feed this baby, okay? If we're testing the blood sugar every 2 to 3 hours and we're feeding this baby and we're having a hard time getting this baby's blood sugar normal, having a hard time keeping this baby's blood sugar normal, then we'll decide to put in an IV and give baby D10, okay? All right, so that's your glucose problems. There's a picture on page 684 of where you will be doing heel pokes on the babies. Very small window where you can do it. It's right kind of like on the corner of the edge of the side of the foot, not on the bottom, not way up on the side, not on the heel. You can do either side of the baby's foot, but in that like edge area, okay? We have talked about jaundice before. Jaundice is the yellowing of the skin because of the bilirubin, increased bilirubin in the baby's blood, hyperbilirubinemia, okay? Bilirubin is stored in the skin, that's why it gets yellow until it's flushed out, okay? If the baby's bilirubin is too high, okay, where now we have bilirubin crossing the blood-brain barrier and affecting the central nervous system, that produces a condition called, in the olden days it was called kernicterus. To be medically correct, it's acute bilirubin encephalopathy, okay? That's brain damage, okay? Brain damage, irreversible brain damage, okay? So that's why we test these babies on discharge, their bilirubin levels, and that's why we pound this into our parents on discharge about signs and symptoms of hyperbilirubinemia. They have the yellowing skin, then their sclera starts getting yellow, these babies get lethargic, then they don't want to eat, then the bilirubin gets worse, and then they get more lethargic, and then they don't want to eat, and the bilirubin gets worse. When they're not eating, they're not pooping, and they're not getting this out of their system. It's a vicious cycle. So we tell these moms, these babies need to eat every 2 to 3 hours, okay? If you can't get your baby to eat, don't say, oh, well, I'll try again in an hour. Make this baby eat. If you have to pump, put your breast milk in a spoon and drip it into your baby's mouth, and that's what you will do, okay? These babies need to eat, okay? And they need to poop this out. Now, if if it gets to the point where the parents are saying, you know, I'm doing everything I can get this baby to eat, this baby is very sleepy, this baby looks orange, they bring the baby in, we do a blood test, the bilirubin is too high, we admit the baby and we put the baby on phototherapy. Okay, so that can be a Billy blanket, a Billy bed, or phototherapy lights, a bank of lights that sits above the baby and shines down on the baby. Okay, this light helps break down the bilirubin that's in the skin, and then baby can excrete it. Okay, now the cause of bilirubin is a breakdown of red blood cells. Okay, hemolysis. Okay, that's a normal process. Okay, but if it happens, if it overwhelms the baby's system, then jaundice occurs. Okay, we can have hemolysis for several reasons. One can be we had a traumatic delivery and baby's all bruised up, so baby has extra red blood cells to hemolyte. Okay, we have an ABO or we have an ABO incompatibility. Now, ABO incompatibility is different than RH incompatibility. ABO incompatibility is kind of common, but we don't even know about it because we don't even really test for it. Yeah, we do mom's ABO. Yeah, we do baby's ABO, but we don't really test to see if we've had some sort of problem. Because even if we did have some sort of problem, it is very mild, very minor and self-limiting. Okay, so this could be going on and everything's fine and dandy. But if it's severe enough, we're gonna, if it is really severe, we're gonna see increased hemolysis from our baby, and we may start seeing an anemic type problem for our babies. But when we talk about the alloimmune hemolytic disease, we're basically saying this is the RH hemolysis issue. Okay, RH negative moms attacking RH positive babies, and if this is severe enough, this is called erythroblastosis fetalis. Okay, we don't see this very often anymore because we don't let the RH negative problem happen very often anymore. Okay, the one time you might see this more often than not is your RH negative mom who gets pregnant for the first time and has an isoimmunization. Okay, she's become sensitized and she's attacking her baby. Well, so this usually happens on subsequent pregnancies, right? Well, how can a woman be sensitized if this is her first pregnancy? Well, she may never have mentioned the fact that she had a blood transfusion several years back and they gave her RH positive blood. She created an immune response to that, and now she's pregnant with an RH positive baby. And so there you go. Okay, so we don't see this very often, but you can see this. Okay, and then a severe form of erythroblastosis fetalis is hydrops fetalis. This is a severe anemic situation for the baby. Okay, now if this is severe enough, we may end up giving baby a blood transfusion, a replacement transfusion, and this replacement transfusion can also or exchange transfusion can also occur in utero if you have a perinatologist. Okay, so that's pretty cool. I've never seen it. I work at CMC and we have a perinatologist there, and I've seen him do some crazy intrauterine stuff, but I've never seen this because, like I said, this does not occur very often anymore. Okay, anyways, so moving on. Okay, so care of the newborn with anemia. If this is not a hemolysis type of anemia problem, this can be an anemia problem due to blood loss, which happened at delivery or with a placental abruption, some sort of maternal bleeding episode, hypovolemia problem. It can be a hemolysis problem But anyways, it's an anemia problem for baby, and hopefully maybe our management for this could be a blood transfusion if it's severe enough, or it just can be maybe even a supplement problem, a supplement problem, replacement for baby, or just breastfeeding and continuing to monitor baby's anemic status, and hopefully that baby rebounds. Hold on a minute. Okay. Okay. The care of the newborn with an infection, whether it is a GBS infection, choreo infection. So mom had an infection, amniotic fluid or membrane infection, whether it's an STD infection, whether it's an infection we gave them, whatever it is, okay? So, excuse me, baby will need to be on antibiotics, okay? You'll see respiratory problems, you'll see hypothermia problems, you'll see glucose problems in your baby, okay? You'll have an irritable baby, or you'll have a lethargic baby. You need to get a NICU transfer right away. They'll put these babies on IV antibiotics, depending on whether they can eat or not. You know, all these things come into play. They should be, you know, if it's just a simple infection, they're on antibiotics. Even if they're on a little bit of supplemental oxygen, these babies should be able to feed on their own. However, you know, depending on the severity, they may end up on TPN, or they may end up on tube feedings, okay? So anyways, just remember that your infant can be born normal and healthy, and everything could be, you could check off all your assessment criterias and everything be normal, okay? And this baby could be normal for an hour, this baby could be normal for 6 hours, who knows, okay? And then all of a sudden, the baby is now super sick, okay? So you gotta be aware of your signs and symptoms, okay? All right, so the other part of your job, once you get all that critical stuff done, is parent bonding. There's a big thing about parent bonding and all that kind of stuff. Don't need to go over that. Let's move on now to chapter 30, postpartum family needs. This is where we're talking about, okay, so your mom has just given birth. Okay, so we're not going to talk about bleeding right now. We're going to talk about your postpartum exam. You know, you do a normal head-to-toe assessment like you do on any person, but a focused postpartum exam, use the Bubblehe mnemonic, okay, and that will break it down for you. Your focused postpartum assessment. We do these assessments on mom after birth. I'm sorry. Every 15 minutes times 4, or for 2 hours. Every 30 minutes times 2, or for an hour. Every hour times 4 for 4 hours, and then you can either go to every 4 hours or every 8 hours, depending on your hospital's policy. Okay, the Bubblehe mnemonic stands for breasts, uterus, bowels, bladder, lochia, episiotomy, and hemorrhoids. It kind of goes down. Okay, so the breasts, you know, in your assessment parameters, you know, you don't need to assess the breast every 15 minutes. Okay, the breast assessment is mostly a well postpartum assessment for these breastfeeding moms. You're just going to you're assessing whether or not their breasts are filling up yet, if they're starting to feel firm and enlarged, or if they're still soft. You're assessing their nipples to make sure that we're not having any soreness, cracking, bleeding, blistering, and that breastfeeding is going well. For your non-breastfeeding moms, we want to make sure that, you know, we're instructing them when their milk does come in, they will start getting engorged, and they don't want to be expressing milk to relieve that discomfort. They want to put cold compresses. They want to take some analgesics, wear a tight-fitting bra, okay? But the uterus, we definitely want to be checking our uterus. We want to make sure it's firm at the umbilicus or below. We want to be assessing their bowels. Well, we don't have to assess those every 15 minutes right after delivery, but we do want to be assessing their bowels. So when their bowels start moving again, we don't want them to be constipated. We don't want them to be on the toilet straining, okay? So, you know, that will be in your kind of normal postpartum routine. Bladder is an important issue right after delivery. We want to make sure the bladder stays empty. You know, we want them to void every couple of hours because a full bladder is a full uterus, and it will prevent the uterus from contracting, and they could be bleeding, okay? We want to assess their lochia, that they're having normal bleeding, and their episiotomy. We want to make sure that it's one, not bleeding, but that you know, it's not swelling up, that we're addressing comfort measures for that episiotomy. You know, if she's having hemorrhoids, we want to provide her with some Tux pads or something like that. And then E, the emotional status. You know, we just want to make sure that emotionally the family is dealing with this delivery, that they're bonding, and if there's any emotional problems, you know, a lot of these will surface, you know, after, you know, the first several hours or maybe the next day when reality starts setting in. So we want to be aware of these things. So we want to provide comfort to her bottom. That could be topical creams, ice packs. Actually, we pretty routinely do ice packs for 24 hours after delivery, especially if this woman is swollen. It will help, and if she's having pain, it will help kind of numb it a little bit. And then we can offer this woman sitz baths, but she can take a tub bath. Okay, because we don't do sitz baths anymore. We don't even have the stuff for them to do it. You can rig a sitz bath up a little bit with a bedpan and a fluid bag and the tubing, and she can let the fluid drain onto her perineum, but we don't have the setup anymore. We used to have these really cool setups, but we don't have it anymore. We just tell her to take a bath, okay? All right, let your woman know that just because she's given birth, that she will still feel what they call after pains, or they're contractions of the uterus, cramping. If she's breastfeeding, she'll feel these more because oxytocin is used to cramp the uterus and to help with the letdown of milk. So she'll feel that when baby breastfeeds. So it's a dual purpose, okay? So that her uterus will cramp and control the bleeding. So anyway, it's just physical comfort for the mom, okay? Rest. Talk to your family about fatigue and resting as often as they can. Resumption of activity. We do want these people to be active. We don't want them sitting around. Why? Because pregnancy is a hypocoagulable state, even postpartum for a while. So we want them to have a good activity level. However, we don't want them to have so much activity that they hurt themselves, okay? So walking and swimming are good activities. Of course, with swimming, you know, she's going to be bleeding, so that might not be good. But heavy lifting, strenuous cardio is probably not something that she should be participating in until her 6-week appointment. Anyways, so there's that. Sexual activity and contraception. We tell them to hold off with sexual activity until their 6-week appointment. And then contraception. Breastfeeding moms are usually put on what they call a mini pill. It's a progesterone only pill. Some women say, well, I'm breastfeeding, so I already have that for contraception. Yes, if you're exclusively breastfeeding every 2 hours, 24/7, but that usually does not occur. Okay, there's a lot of things that can all of a sudden interfere with that, and then she's left without birth control. So I do not like my patients to rely on breastfeeding as a birth control option, but that's their choice. Okay, so all right, so a lot of teaching, family wellness, taking care of mom and babe when she goes home. Okay. C-section mom, pretty much the same thing, except we have the added complication of one, increased pain, pain control needs, activity. She's at now an even more increased risk for blood clots, so we're dealing with those issues. Okay, so pretty much a normal course, but you know, just with the C-section healing, prevention of infection, and things like that. You have a section in your text about the postpartum adolescent. You can read over those. They present their own little, you know, just unique little thing. I mean, here's a still developing person who now has a pregnancy. If she keeps the baby, we now have a very young person taking care of another very young person, and support and nutrition and stuff is a big deal for these people. Nursing care of the woman who relinquishes her baby, kudos to her. Lots of support she may need. She may need. Some of these women, you know, they just adopt out their baby and don't seem to ever have any type of support issues, but be ready to give support to these people if you need to. The obese patient has a, you know, they have additional issues that need to be addressed as well. Nutrition, ability to care for themselves, infection, a risk, higher risk for infection, and blood clot type stuff, and you know, all the things that go along with obesity. Okay, nursing care of the lesbian parents, nursing care of the disabled parent. You can kind of just read through those. I'm not going to go over those with you at this time. Home visits. That's a great program for families, for the public health nurse. Okay. We're going to talk about soreness. Okay, so usually soreness is an issue of a latch problem, so you need to make sure that mother knows how to appropriately latch her baby, but things that she can do to help for soreness, rubbing her breast milk into her nipples. We can give her nipple cream. She can use ice to numb the area. She can use a nice supportive bra. She can use analgesics. Okay, but the best thing is to find out why she's getting sore and fix it, and that's usually a a latching problem. Okay, worsening soreness that produces or a worsening latching problem that produces cracked, blistered, bleeding nipples. Okay, so we need to address that latching problem. We may need to even supply this woman with a special nipple shell so that when she breastfeeds it's not so painful. But anyways, we need to get these nipples healed. We need to make sure we have a proper latching so these will heal and prevent any further problems. Okay. A plugged duct is there's a duct in the breast that's plugged with milk. She needs to latch baby on with the nose pointing to the plug. She needs to massage above the plug, through the plug, down towards the nipple to release that plug. All is well. The plugs can be a little painful and sore. She can put some heat on it, and then we need to get that plug worked out so that we don't have an increased risk for mastitis. Mastitis is an infection in the breast. It will be sore and tender, maybe red and warm. She will have flu-like symptoms. She will have a fever, bed rest fluids, analgesics, and possibly even antibiotics. Engorgement is when the breasts fill so full of breast milk that her boobs are rock hard. Okay, makes it very difficult to latch baby on. I instruct my parents to make sure they stick to a feeding schedule every 2 to 3 hours, that baby is actively nursing during those times and emptying the breasts. and that if she does get engorged, that she uses some warm compresses before feeding, and maybe even a hot shower before feeding. Maybe that she hand express a little bit just to make it so that baby can latch on. And then after feeding, to use cold compresses. Okay, I'm going to put you on hold here again for a minute. Okay, moving on. Go through this. So home care for the newborn, just teaching your parents, especially your dads, how to actually hold a baby. So on page 765, there are some, pictures of how to hold the baby, bathing the baby. You can read over that section. Babies will be sponge bath until their cord and or circumcision are healed. And then they can start doing tub baths, but you want to, use a baby tub, not the big adult tub. The parents need to have hands on it the whole time. Nail care, dressing your baby, temperature. They don't have to take their baby's temperature every day, but instruct them on the, what we want their temps to be. 97.6 to 100.6 is kind of a normal axillary temp. We want to teach them about the stools and the voids. Breastfed babies will have that gray poupon-y, cottage cheesy looking stool, and formula fed babies will have and it'll be just kind of like mush, like you mixed up gray poupon-y, cottage cheesy type looking stuff, and then your formula fed babies, their stool will be a yellowy brown, and it'll be more formed than breast milk stool, but it should never be hard. Babies shouldn't have to deal with constipation, but formula-fed babies may. They shouldn't have diarrhea, so it shouldn't be liquid. They should never see green. Okay. Well, like the meconium, as the meconium transitions to formula or breast milk stool, it'll go from that black to a dark green to maybe a lighter green brown. Okay, but when they're home and it's diarrhea, we don't want, they could see greeny blood tinged diarrhea, and this baby needs assessed. It's not gonna be a crazy thing, but added to that, babies will spit up. Bottle-fed babies spit up more than breastfed babies. If bottle-fed babies are spitting up with every feed, the parents are like, oh my gosh, my baby has a milk allergy, and they start changing formula, and they just really screw up the baby. Okay, so this needs to be, we really want to encourage our families to seek some sort of healthcare professional before they start doing all these things, because babies may be spitting up because these people are just overfilling their gut. Bottle-fed babies, it's easy for a bottle-fed baby to be overfed. Okay, so that might be an issue. It may be an intolerance issue, but let the doc or the nurse or whoever help you determine that. Okay, but if babies are spitting up green, that's never good. Okay, so we want to make sure that when these babies are spitting up, that parents know to report anything that's green. Okay, anyways, moving on. Sleeping, crying. It's normal to cry. Babies cry to tell you stuff that they need. But there is a period around 6 weeks where baby's crying seems to be unresolvable. You cannot comfort this baby. There's nothing you can do. It's just a period of time when baby's crying has increased, and it just seems to be you can't console these babies. Okay, it's a normal thing. There's nothing wrong with the baby, and there's nothing wrong with the parents. However, in the parents' attempt to stop these babies from crying, they can literally go insane. And I said literally, but it can be very frustrating when you have this screaming baby all the time, and you're super exhausted, and you can't get this baby to stop crying. Okay, so these parents can be very overwhelmed, and it doesn't always So shaken baby syndrome, when we have babies that are admitted for shaken baby syndrome, this does kind of correspond to this 6-week period of increased baby crying. There's a video called Period of Purple Crying. If you guys want to take some time to look at that, it's really kind of interesting. But otherwise, just know that it's the period in which babies cry the most. It puts babies at risk for shaken baby syndrome. And we need to instruct our parents, like, do not continually try to comfort your baby, okay? Because it won't work. You're not doing anything wrong. There's nothing wrong with your baby. It's just not going to work. Put your baby down in their crib and shut the door and leave the room, okay? Go take a break, okay? Because your baby's going to cry whether you're with them or whether you're not. But if you love your baby and want to protect your baby and make your baby happy, put them down and leave the room. Do not shake them, okay? So anyways, tell them it's okay. All right, anyways, moving on quickly to our last chapter, postpartum families at risk. Okay, this is where we're going to talk about hemorrhage. So I told you there's an early and a late hemorrhage. An early hemorrhage is the hemorrhage that happens, right after delivery or within 24 hours. The late hemorrhage happens after that and can happen anytime up to 6 weeks. Okay, early hemorrhage. Usually the primary reason for early hemorrhage is uterine atony. So they've delivered their baby and for whatever reason their uterus is not clamping down like we want it to, okay? There's a list of several reasons why that might happen. Now you remember in lecture that we talked about the overdistended uterus. So that's because we have a macrosomy baby, we have a hydramnios, we have a multiple gestation. So our uterus is over distended, okay? So when we have something that's over distended, then sometimes its ability to cramp and contract down is diminished, okay? Because we've just stretched those fibers beyond. It's like stretching a rubber band beyond its point at which it won't recoil anymore, okay? Same concept with your grand mal tip person, your person who has had several pregnancies. The uterus has been stretched several times. Same thing with the rubber band. You keep stretching this rubber band repetitively, eventually it's not going to recoil like normal, okay? With a dysfunctional or prolonged labor, so this is like going to the gym and working your biceps for 8 hours. Okay, eventually you'll get to the point where you can't even lift a cup of water to your mouth. Okay, that muscle is exhausted. It just won't work anymore. Same thing with a prolonged or dysfunctional labor. That uterus is just give up. It's exhausted. It can't work anymore. Oxytocin is another reason. Now, oxytocin is the medication we give to help a woman cramp, contract, and control her bleeding after delivery. So why would it be the reason why we can't cramp, contract down? Well, if we've given oxytocin, large amounts of oxytocin for several hours in labor, we may have saturated the uterus, okay? So there's only so much water you can fit in a cup before it won't accept any more water, okay? Same thing with the uterus. There's only so much oxytocin you can put on that uterus before it can't even accept any more Pitocin, therefore the Pitocin isn't working, okay? So anyways, you can look through those reasons there. But the reasons why those are listed there is so that you can be prepared for uterine atony, okay? And then take care of it. Now, how do we take care of it? Well, first line is uterine massage. If I'm massaging her uterus and I'm not getting her bleeding to slow down, maybe the physician will go in through her vagina and massage the bottom part of the uterus while I'm massaging the top part of the uterus, or he may be massaging both, okay? Bimanual massage. If there's retained placenta fragments in the uterus, so that's another reason for early uterine atony. The uterus is not able to contract down efficiently enough, because there's still some placenta parts in there that will cause her to continue to bleed, the physician may need to go in and manually remove those things, okay? But retained placental parts is also a reason for the late hemorrhage, okay? So there's parts still in there. Her bleeding has been normal after delivery. It remains normal. We send her home. It's still normal. And then somewhere, around 3-5 weeks or something, now she starts bleeding because of that retained stuff, okay? Anyway, so we do the massage. The next thing that we do is we will give her Pitocin IV. And then if that doesn't help, we might give her Methergin IM, okay? And the physician may even give Methergin intrauterine, right through the uterus. And then, or we can give Cytotec rectally. And sometimes we just go straight to the Cytotec. It works very well rectally, okay? Anyways, so she may have hematomas that are developing. So she had a break in the vasculature in the tissue, which is what a bruise is. But in the vagina or the labias, she can really fill up with a lot of blood, okay, to the point of hemorrhage in these hematomas. These hematomas will start swelling, and they will be very, very, very painful, okay? So we may need to surgically repair these hematomas. Anyways, so episiotomies and lacerations, well, if you didn't stitch the episiotomy well enough, it may continually ooze blood. Lacerations, so maybe she had some cervical or vaginal lacerations that the physician wasn't able to see. It's very hard to see that stuff inside. And so those may continually bleed to the point that she may be hemorrhaging, okay? And then your late hemorrhage is, it could be from lacerations that maybe initially clotted off after delivery and we sent her home, and then that scab or clot broke loose and now she's bleeding from those. It could be retained placenta. So anyways, we want to instruct her about bleeding at home. We don't want her, we want to instruct her that we don't want her soaking a pad every hour or every 2 hours. We don't want her having heavy bleeding or a heavy period like bleeding. So anyways, she needs to call and let us know about that, okay? So postpartum infections or puerperal infections. So this could be endometritis, some sort of genital tract infection. This could be okay, so let's just stay with the genital tract infection. So one of the, she'll have a fever, she'll feel sick. She may just have her lochia may have a very terrible odor. And the problem with this is, this is embarrassing to the woman. She may not report this, okay? So we need to let her know that this is not her. She's not a dirty, yucky, nasty girl, that she has a uterine infection. She needs to see the doctor, okay? Other infections she can have is a UTI, or, a pyelonephritis. We want to teach her signs and symptoms, and tell her to make sure she calls her doctor to get antibiotics. This section does also talk about mastitis, but we have talked about that. The next thing we're going to talk about is embolic disease, a thrombosis, a thrombophlebitis. We need to instruct our patients on a clot, pain in the calf, warmness, redness. She could have a fever. She needs to report these. We need to know about patients that are increased risk for developing a clot and really educate them. Some people come into pregnancy with a clotting disorder, and then they are now pregnant, which is a hypocoagulable state. So some of these people may be on some sort of Lovenox therapy prenatally, and then they get to us in labor, and we start them on heparin drip. We need to be able to titrate this. We don't want to shoot them with Lovenox and not be able to take our Lovenox away or add more Lovenox. So that's why they're on heparin during labor. And then postpartum, they'll be on Lovenox for a little while, and then if it seems like they need anticoagulation beyond the 6-week period, they may be switched over to Coumadin. Okay. So psychiatric disorders, postpartum depression, can be as simple as baby blues. So this woman is, is just moody, tearful, and she just needs support, and needs to know it's okay and stuff like that. She could actually progress to or have postpartum depression, where it's a little more severe. She's a little more depressed. She might need to be on antidepressives, medication, or even just as simple as some B12 injections or something like that. But then we want to watch these people for postpartum psychoses, where people may be unsafe. Okay, so we need to instruct these women and their families, to really report any problems, so that they can be treated and we can prevent any craziness from going on. Especially the family, the woman may be in denial, she's not depressed or whatever. The family needs to be able to know that they can report as well. There was one other thing I was going to say. Some facilities do a postpartum depression assessment before discharge, and depending on where this woman scores on this postpartum depression, they will alert the physician to her score, and he may prescribe her before she even leaves the facility an antidepressive. Okay. All right. That's all to my review. Good luck on the exam.